I want to talk a little bit about this practice question that's caused a lot of problems for medical students. You can see we're here at L5 and we've got a shading or a lesion of the anterolateral system. We've got some shading up in here which sometimes mistaken for the dorsal spinocerebellar tract, and in fact it's the most laterally placed fibers in the lateral cortical spinal tract. And then we've got some shaded fibers up here medial in the fasciculus gracilis. I think the biggest point of concern is this pathway here, the ALS, so why don't we do a little bit of reviewing. There's a cell here and there's a cell here up in the dorsal horn. These dorsal horn cells at L5 get their pain and temperature information from S2, but there's still dorsal horn cells at L5. So this dorsal horn cell will send its axon down in here into the most medial part of the ALS at L5. This L5 dorsal horn cell will send its axon in here. Now, don't forget these L5 dorsal horn cells and their axons are carrying information from S2, but they still have entered here. So this dorsal horn cell at L5 is in the ALS at this level. Now, if we go down to the S1 level, we can take a dorsal horn here and a dorsal horn here. Now, they're being turned on by information, pain and temperature information from S2, but these are dorsal horn cells. A dorsal horn cell at S1 has an axon that comes in here in the most medial part of the ALS at S1. Now, granted, they're carrying information from S2, but still, this is a dorsal horn cell at S1. It's in the ALS, opposite ALS at S1, so it's got to be in the ALS at L5. This shows classic amyotrophic lateral sclerosis, which is an upper, that is, lesions of the LCST, lateral cortical spinal tract, here and here, and lower motor neuron deficit at the same time. So with the upper motor neuron problem, for instance, in this case, you could probably have a lot of spasticity down in the lower extremity, and at the same time, you're going to have lower motor neuron problems in the upper extremity. So here you have a lower extremity spasticity, upper extremity around C8 deficit, lower motor neuron. This will be in the same patient. These patients have a lot of fasciculations, which is indicative of the lower motor neuron dying. So upper motor, lower motor neuron, same patient. Syringomyelia, we did this in class one day. This cell right up in here would be turned on by pain and temperature from T3. Same for this. If you interrupt the axons here, you're going to have a bilateral loss only of pain and temperature, only at T3. Now, Dr. Rutecki talked about a lesion in here, a cavitation or a syrinx, that went probably from T1 all the way up to C4 or something. So a long syrinx in here. In this particular case, you're going to have a lot of problems. You're going to have problems of these crossing fibers from T1 up to C4, so it's going to be over a larger part of the body, but it's still going to be bilateral. And in these cases, syringomyelia, where it goes a number of levels from T1 up into the cervical cord, it gives a very cape-like distribution. Subacute combined systems disease, Dr. Rutecki didn't talk much about it. He does have a practice question. In the combined systems, you're going to have the problems up in the dorsal columns. So this is going to give you your classic 2-point vibration conscious proprioception loss. You're also going to have a Romberg, positive Romberg sign. Come into the lateral cortical spinal tract on both sides, you're going to have your classic upper motor neuron problems. This is due to vitamin B12 deficiency, and don't forget the old tabes tosalis, which is involvement of the dorsal column system. Now, sometimes in subacute systems disease, you also get the fibers in the dorsal root. Okay, so if you kill these fibers in the dorsal root, then of course you could have some of the axonal problems that Dr. Lotz talked about. For instance, if the axons are dying that eventually go out into here, you can have changes or not in conduction velocity. If this would affect the myelin of these sensory axons, of course you would have a problem in conduction velocity. Here we have a classic description over here, or outline of the dermatomes. And I think it was pretty clear from what Dr. Rutecki said, which dermatomes he wanted you to know, especially in the upper extremity. For me, the easiest one is the C6 over here because we call it the six shooter. So if you put your thumb and finger out kind of like you're going to shoot somebody, that'd be the six shooter, C6. C7 would be the middle finger. Of course, C8 would be the lateral, the little finger right here. So I think you should know C6, C7, and C8. As far as the motor side, he said the most problems that you're going to see when you're out in business is going to be a radiculopathy of C7. Now, you should know that the disc that would cause this would be between C6 and C7. So you would have an effect on the triceps reflex. And what else? I think we already know CAT1, intrinsic hand muscles. Those are probably the most popular ones. When we look at radiculopathy here, again, I think we should concentrate on C7. All right, and you can see that there's always a little bit of back pain here because don't forget these roots are coming out and supplying some of the periosteum around the vertebral column. And then you can see its distribution here. So you can see a dense, probably get some shooting pain here in the middle finger, some loss of sensation in the dotted areas. Now as you go back through here, you probably get some deep muscle pain, and even some of these axons innervate the periosteum. So it can be some very diffuse painful sensations coming from the bone. So this would be C7. C6, again, the old six shooter. I'd know this one pretty cold. And C8 out here, the little finger. So those are the classic ones. In the lower extremity, I think he really emphasized L5, the big toe. S1 out here more laterally to the little toe. As far as the muscles, L5, you should remember now, it's going to help you dorsiflex your ankle. So if you have a lesion of the L5 root or a problem of radiculopathy of L5, you're going to have very much difficulty standing on your heels. And S1, again, it's going to have, here you're going to have a problem with standing on your toes, okay? So think about the S1 and the L5. Here, you're going to have difficulty standing on your heels. Here, because it's a plantar flexor, you're going to have trouble standing on your toes. If we look at these again, L5 is the real important one, S1. L5, big toe, but also some other areas that you should know, okay? L5. And here's your S1 out here coming along the lateral surface. So to get an L5 radiculopathy, you're going to have a disc problem between L4 and L5. To get an S1 radiculopathy, you're going to have a problem between L5 and S1. This really shows it. Here's the disc right here, intervertebral disc between L4 and L5, and you can see it's getting L5. Here's a disc between L5 and L6, and this would go in and get this L5S1 would go in here and get the S1. Let's talk a little bit about respiration. I didn't talk much about it in my lectures, but it's very important. What you need to know is here we have a typical drawing of the cervical cord, and you should know from gross anatomy that there are neurons at C3, C4, C5 that innervate the diaphragm right here via the phrenic nerve. And these neurons receive their innervation from cortical pathways that you don't know, and some medullary respiratory pathways that we'll talk about pretty soon. But these pathways, as you can see from the diagram, are traveling in this ventral funiculus here. And if you were to interrupt these pathways in the brainstem or in the spinal cord, before they get to these lower motor neurons here that are going out to innervate the muscle of the diaphragm, you're not going to be able to cause these lower motor neurons to contract, therefore you're not going to be able to cause the diaphragm to contract. So lesions up in here, especially bilateral, you have to have a bilateral problem with this pathway. So any lesions up in here or rostral to C3, C4, C5, that is above them, these lower motor neurons are going to lose their control signals from these respiratory centers of cortex, and you're not going to be able to breathe. Now don't forget, some of these fibers are going to continue on down to also go to some of the lower motor neurons in the thoracic cord that also help you breathe. But any lesion rostral to C3, C4, C5, you're going to have to be put on a respirator. Now, you can have lesions below C5 in this ventral part of the spinal cord, below or caudal to C5. Your diaphragm's going to be okay. You'll have a little problems with the intercostals, but your diaphragm is in good shape. The key here is by a big lesion interrupting this descending information. Say it's C2. If you interrupted this at C2, you're not going to have any diaphragmatic movement, and you're going to lose that innervation to the intercostals. Okay? If you get below C5 in the ventral funiculus, then these fibers have already gotten off to turn on these phrenic lower motor neurons, and you're just going to lose that innervation to the thoracic cord. Now the bladder is kind of interesting. What we usually think about with the bladder, I mean, a lot of people want to get concerned with all the various connections down here into the bladder, and I think what Dr. Rutecki really emphasizes is that you need to think about this whole system in an upper and lower motor neuron type of situation. There are preganglionic parasympathetic neurons in the conus area, S2, S3, S4, that sends preganglionic parasympathetic fibers out to a postganglionic neuron, and then that postganglionic parasympathetic goes into the bladder. You can see it on both sides. There are also dorsal root ganglion cells that are bringing information into this conus area about how much stretch is on this bladder. Okay, so let's just take what would happen if you had a descending pathway up here that prevents the descending information from ever getting from these preganglionic parasympathetic fibers. Well, let's just consider these preganglionic parasympathetic fibers as lower motor neurons, even though we've got these postganglionic neurons interposed. But let's just consider this lower motor neuron. Well, what would happen if you lost the cortical spinal input to lower motor neurons? Well, actually, the first thing that would happen is that you'd have flaccidity. The spasticity would not come in immediately. So you'd have spinal shock. Okay? So you cut these, and just like your muscles of the arm or leg, you've lost this upper motor neuron innervation, and you go into spinal shock. So what would happen to the bladder here? Well, the bladder is going to fill, but nothing's going to happen. It's just going to fill, and you're going to have what is called an atonic bladder. It'll fill, and then after it's so full, it might drain just a little bit. But it's just very much like a lower motor neuron lesion. It's like what happens in spinal shock. You don't have any reflexes right away. Then later on, you get the spastic reflexes. So it's the same thing here. Right after a lesion, above this conus medullaris, it's just like a lower motor neuron lesion. Immediately after you have this upper motor neuron problem, you're going to go into spinal shock. This thing has no tone. So it'll fill, and maybe spit out just a little bit. Later on, just like your arms and legs with an upper motor neuron lesion, you start getting the spasticity setting in. Once this is a spastic bladder, it's going to fill a little bit, spit it out. Fill a little bit, split it out. It's just like moving your arm. Spastic arm, you move it a little bit, it contracts. You move it a little bit, it contracts. So right away, after an upper motor neuron lesion, you've got an atonic flaccid bladder. But pretty soon that spasticity comes in. You fill a little bit, it spits it out. You fill a little bit, it spits it out. It's just like when this takes on more fluid, it's going to stretch. It's going to go in this muscle spindle, and it's just going to be like a reflex, a very hyperactive reflex. So right after the upper motor neuron lesion, atonic, no tone. Then, 2 or 3 days, 2 or 3 weeks later, a spastic bladder. So you get both a atonic or a flaccid bladder with an upper motor neuron lesion and a flaccid bladder with an upper motor neuron lesion. So don't forget, first you're going to get an atonic, then you're going to get a spastic. Now what happens if you just go in here and cut all these nerves in here? Well, this is just like a lower motor neuron. There's no way that this is ever going to get spastic. So here you're cutting all these nerves. I mean, if you start to stretch this bladder a little bit, you send in this muscle spindle information, nothing's going to happen. It's not going to even get in. Then it couldn't do anything anyway. So here you're never going to get a spastic bladder. It's going to be atonic bladder. It's going to fill. So in the case of an upper motor neuron lesion, you get both a flaccid or atonic bladder followed by a spastic. With what we call a lower motor neuron lesion down here, you can never get a spastic bladder. It's just going to be atonic. Now, I mentioned earlier syringomyelia, and I just wanted to show you, here we have a lesion here of the crossing fibers, pain and temperature fibers, at C2. So many students have asked me about this drawing. Of course, if your lesion was just here at C2, you'd lose pain and temperature from C4, only C4. But this lesion obviously is running throughout the cervical region because it probably runs from C1 or C2 all the way to C7 or C8. Because just think, if it ran to C7, pain and temperature would be lost from T1. So just think about that. This is probably this cape-like distribution of the loss in pain and temperature is resulting from a lesion that runs throughout most of the cervical levels. Now, don't get confused between the cape distribution and the glove and stocking distribution. It's been my experience in the past that students confuse this with caping, the cape-like distribution of the syringomyelia. Here we need to think about a polyneuropathy. That is, every nerve that's projecting down into here is dying. All right? So, and every nerve projecting into the hand area is dying. And you can see you're not only going to lose sensory information, but you're also going to lose the ability to move the muscles. So for instance, in this polyneuropathy right here, if you were to test this person's reflexes, they'd be shot. You wouldn't get a reflex there. If you were to test them for two-point discrimination, they wouldn't have it. So here we have a case where we lose two-point discrimination. We're not in the dorsal column, so you need to think about that. So you're losing sensory and motor. Now remember, Dr. Lotz said that as people get older, the one thing they really complain about with these polyneuropathies is burning from their feet, during the night. And that's because these nerves also have smaller fibers. So in addition to the information about two-point, etc., they've got smaller fibers. You know, those are pain and temperature. And when they start to die, you get this burning sensation. So don't confuse the glove and stocking distribution loss with the polyneuropathy and the cape-like distribution with syringomyelia. Now I'd like to talk about this chart that is a really good summarization of all of Dr. Lotz's material. So what I'm going to do is I'm going to go across from left to right here, and we'll briefly discuss each one of these boxes. First, we're going to talk about anterior horn cell disease. That is, this would be in the spinal cord. Your lower motor neurons in the spinal cord would be damaged. Some of them would be dying. A good example of this would be spinal muscular atrophy, or polio. And these lower motor neurons are dying, and their axons are therefore going out into various nerves, and they're degenerating, and they're going out eventually to muscle. So if we moved here and we start talking about conduction velocity, if you think about some anterior horn cells dying in the spinal cord, but some of them are still alive. And let's say some of the live ones are out in the nerve along with some of the dead ones. So if you do a conduction velocity, if you stimulate that nerve, the conduction velocity is going to be okay, because the axons that are alive are going to cover up for the axons that are dead. But the conduction velocity is going to be okay. Now, with this anterior horn cell loss, again, some of the axons in the nerve are dying and some of them are alive. But when you stimulate this nerve, the dying axons are no longer going to turn on the muscle fibers in the muscle. Now granted, you can have some re-innervation, but in general, when you have dying axons coming out of the ventral horn in these branches in the nerves, when you stimulate the nerve, you're going to have a decrease in a compound muscle action potential. That is, all the muscle fibers that are firing when you stimulate the nerve. So some of the axons are dead in the nerve, So you stimulate it and you're going to get a decrease in the CMAP. We don't have to worry about the sensory nerve action potential in a motor axon. Repetitive stimulation is okay. That is, when you stimulate the nerve with the dying axons in it, the CMAP is going to be down, but it's not going to decrease in size as you repeatedly stimulate it. Now, since some of the axons are dying that are coming out of the ventral horn, you're going to have some reinnervation, and that means that the motor unit potentials would be larger. All right, because usually a motor unit is going to innervate a certain number of muscle fibers. But if some of those muscle fibers are losing their neuronal innervation, you have some reinnervation, so those motor units that are alive are going to take over more muscle fibers, so you're going to get an increase in the size of the MUPs. CK is only going to go up when you have a myopathy, something wrong with the muscle. Of course, you're going to have type grouping and group atrophy anytime that you have axons dying in a nerve and reinnervation in the muscle. And when you get this, of course, then you're going to have the larger MUPs. Fasciculations are very different from fibrillations. Now, fasciculations you can actually see. You don't need a little microelectrode to go into the muscle to record a fasciculation. And the most common time you're ever going to see fasciculations is in amyotrophic lateral sclerosis, when those ventral horn cells or anterior horn cells are dying, and you get these visible twitches. But these twitches are very sporadic. They're not at regular time intervals. So this would be a fasciculation, is something you actually see, usually when the lower motor neuron is dying in the cord. And these are just basically motor unit potentials that are firing as the axon's starting to die. You also see fibrillations, which are actually, the only way you're going to see these is with a recording electrode in the muscle. And these are going to be the result of the actual single muscle fibers that have lost their innervation. Now they're firing. Okay? Now fibrillations can occur both when you're losing axons and having reinnervation and when your muscle is actually dying. But fibrillations you cannot see. You need a little microelectrode to go in there and see them. And they represent the damaged instability of the membranes around individual muscle fibers. Now, in the case of a peripheral nerve damage, especially if the axis cylinder or the axon is damaged, if you look at the conduction velocity of a axonal peripheral nerve problem, the conduction velocity is going to be normal because the alive ones are going to camouflage for the dying ones. The compound muscle action potential is going to go down because the axons are dying and you can't turn on as many muscle fibers. If it's a sensory nerve, since the axons are dying, you stimulate that nerve and the sensory nerve action potential. That is when you're registering all the action potentials in that nerve, of course, if some are dying, the sensory nerve action potential amplitude is going to be down. Repetitive stimulation is only seen in myasthenia gravis, so we won't have to worry about that, the decrement that is. MUPs are going to be larger because the axons are dying and there's reinnervation. Blood CK you don't have to worry about except when the muscle's dying. And when you have the axons dying, you're going to have type grouping and group atrophy. Fasciculations, of course, again now, these are very sporadic and visible, and fibrillations are smaller and they're more regular firing sequences. In the case of the peripheral nerve where you just lose the myelin, now you're going to, even though those axons are alive and well, you're going to have a decrease in the conduction velocity. Since the axons are okay, your CMAP's going to be fine, your SNAP's going to be fine. Repetitive stimulation, again, the only time you get a decrement in that is in myasthenia gravis. And again, here your axons are okay. So when you stimulate, even though the myelin is dying, you're still going to have a normal CMAP. You're not going to have any MUPs because axons are dying. Blood CK you're only going to see in myopathies. You're not going to see any fasciculations or fibrillations. The axons are not dying. And the muscle fibers are alive. In the case of myasthenia gravis, which is just a problem of the neuromuscular junction, that is the acetylcholine receptors are shot, of course the conduction velocity is going to be fine. CMAP is going to be fine. Sensory nerve action potential is going to be, this is the key, decremental CMAP. That is, every time you shock the nerve, the compound muscle action potential is going to decrease from the first to second to the third to the fourth. Your MUP's going to be fine because your axons are okay. Blood CK isn't going to be affected because the muscle isn't dying, and you're not going to have any fasciculations or fibrillations. In the case of a muscle disease, no matter, you can stimulate that nerve, and even though the muscle's dead, you're going to have normal conduction velocities. Because the muscle is dying, you can shock the nerve, but you're not going to be able to turn on those muscles, individual muscle fibers, so your CMAP is going to go down. This is not really important, and repetitive stimulation isn't important because the muscle's dying. MUPs are going to be smaller, right, because muscle fibers are dying, so when you stimulate a motor unit, it's not going to be turning on as many muscle fibers. Blood CK is going to go up. The muscle's dying. Muscle's dying. You're not going to have fasciculations, but in muscle disease you are going to have fibrillations, because as those muscle fibers die and they become broken apart and become isolated from their neuromuscular junctions, you're going to get an unstable membrane, so you are going to get a fibrillation. In the case of an upper motor neuron lesion, you don't have to worry about anything on this chart.